Hi everyone, I'm Sarah Ali. I will talk about the second part of our seminar, which is the fracture of the mandible. Teeth in the line of a fracture. Teeth in the line of a fracture may cause infection of the fracture site, either from the oral cavity عن طريق a disrupted periodontium or directly from an infected pulp or chronic periapical infection. Infection of the fracture site will result in a protracted healing or even non-union. So we have absolute indication for removal of a tooth, which is longitudinal fracture involving the root, dislocation or subluxation of a tooth from its socket, presence of periapical infection, advanced periodontal disease, where the displaced tooth prevents a reduction of the fracture, and acute pericoronitis, which is associated with unerupted or partially erupted third molar. We have a relative indication for removal of a tooth, which is functionless tooth, doubtful teeth, which can add it to the existed denture, and advanced caries. إذا ما كان عندي أي indication من الأبسوليوت ولا relative, we can manage the retained tooth عن طريق administration of the appropriate antibiotic therapy, supplanting of the mobile teeth, endodontic treatment and follow-up for 1 year, and immediate extraction if the pulp becomes necrotic. Now we will talk about the complication of the mandibular fracture, which can be divided into early and late complication. First, we will talk about the early complication, which is misplaced fixation, nerve damage, anesthesia or paresthesia of the lower lip as a result of an injury to the inferior dental nerve is the most common complication of a fracture of the body of the mandible. Damage to the inferior alveolar nerve can also result from treatment, which is most commonly associated with open treatment. Facial nerve damage may complicate some fracture of the ramus and the condyle. 3 اللي هو infection of the fracture site. The main contributed factor are compound fracture with cross-contamination, inadequate stabilization, loose fixation devices, immunocompromised patient like diabetic or alcoholism. The fracture should be prevented by good antibiotic prophylaxis, maintenance of wound hygiene, adequate immobilization, ensuring that the fixation devices are not loose, effective management of teeth involving in the line of a fracture. The principles of management are control the infection, incision and drainage and antibiotic, remove any focus of infection like teeth, sequestra or plate and screw, optimize the healing environment, patient health, oral health, immobilizing the fracture. Now we will talk about the late complication, which is malunion, which means the healing of the fracture is an abnormal or non-anatomical position. يكون نتيجة إلى inadequate occlusal reduction during surgery, inadequate osseous reduction during surgery, imprecise application of internal fixation devices, inadequate stability. If the malalignment is noticed early, we can return the patient to the operating room for repeating the reduction. Minor malunion do not usually cause a major clinical problems because the dentition often readjusts to a new bite, while a significant malunion can cause a gross occlusal derangement and facial deformity, which can be resolved by operative reconstruction, usually in the form of refracture or planned osteotomy or osteoctomy with rigid fixation. Bone graft may be required in some cases. Delay union, which is mean the union of a fracture segment is delayed beyond the expected time for that particular fracture. Non-union can caused by general or local factor, which is infection of the fracture site, inadequate immobilization and excessive mobility, unsatisfactory apposition of the bone which end with interposition of soft tissue, the ultra-thin edentulous mandibular in elderly patient, loss of the bone and soft tissue as a result of severe trauma, inadequate blood supply, for example after radiotherapy, the presence of bone pathology like malignant neoplasm, and general disease like osteoporosis. التريتمنت راح يكون identify the cause, controlling an infection, surgical reconstruction اللي يكون يتضمن removing of the existing hardwire or plate, debridement of a vital bone and or soft tissue, decortication of a bone fragment at the fracture end, re-establishing the occlusion and stabilization of the site by plate and autogenous bone graft to this area. The complication associated with internal fixation اللي هي تكون exposure of a plate, especially when placed near the oral mucosa like we see in this picture, infection, transosseous wire may cause pain or discomfort. Now we will talk about the fracture of the condyle. Fracture of the condyle represented around 25 to 35% of all mandibular fracture. Several classification systems have been developed, but for practical purpose, the anatomical level of a fracture is divided into three sides, which is condylar head, intracapsular, condylar neck, which can be divided into high and low, and subcondylar region. The fracture is further classified as no displacement, deviation, displacement, lateral override, medial override, deviation, dislocation, and displacement dislocation. Radiographic imaging, we can use OBG, bilateral oblique, down view, reverse down view, CT, and CBCT. Management of a condyle fracture can be conservative functional therapy or surgical treatment. Most cases of a condylar fracture are best managed through non-surgical means to reduce the complication associated with surgery. So, a condylar fracture without displacement do not require any treatment. Just the patient is asked to restrict the movement and semi-solid food diet intake for 10 to 15 days followed by active movement. In case where condylar fragment overriding is seen with alteration in ramus high producing malocclusion, initial elastic traction is given to correct the malocclusion, followed by intermaxillary fixation for 2 to 3 weeks. In case of deviation on a mouth opening without much occlusal discrepancy, a simple muscle training is adequate. And we should know that early immobilization is advocated in cases of young children to avoid ankylosis of TMJ. Close reduction, indication for close reduction يكون condyle neck fracture in children below 15 years, very high condyle neck fracture without dislocation, intracapsular fracture, grossly contaminated fracture, and gunshot. Open reduction with internal fixation of the condylar, we have absolute indication اللي هي displaced of the condylar, lateral extracapsular displacement, invasion by foreign body, impossibility of restoring the occlusion with a close treatment. Relative indication, bilateral fracture with associated mid-face fracture, bilateral fracture with severe open bite like pictures, unilateral fracture with dislocation when an intermaxillary fixation is contraindicated for medical reason. We have surgical approach for an open reduction. We have extraoral approach and intraoral approach. Extraoral approach, we have preauricular, which we can see in this
to fix the L-shaped
video.
Plate, 4-hole plate without cleft. Feel for the
As we see
zygomatic
here, the
arch
fracture
and
of the
straight
condyle
anteriorly and downwards. You will find the
exposed.
avascular cleft, and you can see the fracture now. The condylar area.
And we have a retromandibular or transparotid approach. This is